So we have this 11-month-old child who was diagnosed to have laryngomalacia around 3 months of age, was tracheostomized for the same in view of severe obstruction and referred to the ENT department for decannulation. So this child has been on the tracheostomy tube for almost 7 to 8 months. And parents are very keen on decannulation, and so they are referred here. Elsewhere, the decannulation was attempted but immediately failed, and so the child was put back on the tracheostomy tube. And here we had admitted this child in a modified sleep lab, which we do in the ER and the ICU. This is the way the child is breathing at night. You see that. You can see that pattern of breathing. It's almost like the child is on high frequency ventilator. Look at that fibrillatory efforts of the chest. It's like 60, 70. This is not tachypnea. This is just it's actually hypoventilation. There is no effective good breath. All the breaths are like literally fibrillatory, and that is correlated by the monitor. That's the first is the heart rate. The second is the saturation on room air seems to be good. That's the respiratory rate. Those efforts that you're seeing in between are the good efforts. But in between those good efforts, you have those fibrillatory movements. Those are the hypoventilated breaths. And the last one is the ETCO2. ETCO2 number is high, irrespective. Look at the pattern. These spikes which you see, these are the, ineffective or hypoventilated breaths. And in between what you see, that slightly better graph, is probably a near normal respiratory effort. So this child actually has hypoventilation. It is called urine. It happens during sleep. When a child sleeps, the respiratory drive from the center is kind of blunted and the respiratory efforts are bad. Let's look at the same child when he's awake. Almost normal looking, happy. Respiratory efforts are fine. ETCO2 is still about high, 52, but look at the graph. Many normal breaths in between. Completely well-looking child. So he himself is showing the respiratory effort. Happy, active, no fibrillatory movements, normal chest movements. This is called a central hypoventilation or Nondine's curse. It goes back to mythology where because of some curse by somebody, that person could not breathe well while sleeping. So this very rare in children, but yes, we being a tertiary center, we get these referrals. So this child had to go back on home BiPAP at night, and is actually coming this week sometime. The child is right now 5 years old. He's coming sometime to see if we can do a sleep study and take a call on decannulation. So this is a central airway pathology. I mean, I wouldn't call it an airway pathology, a central lack of drive where the breathing pattern is affected because the center does not give, the brain stem does not give the necessary input to the muscles to breathe. Very rare, but yes, the pattern can give you a lot of evidence. A 15-year-old with fever, altered sensorium for 1 day, and 1 episode of seizures that particular morning. GCS is only 7. He's breathing at 5 to 8 per minute. Heart rate is 67, BP 110. SATs are normal. Tone is slightly decreased. Pupils are mid-dilated. Reflexes are diminished. Again, pay attention to the breathing. So you can see that particular child, you know the history, the sample history, something like a meningitis, encephalitis, meningoencephalitis. Again, a central kind of a breathing pattern where the drive is gone, the child is an altered sensorium. and the child is breathing only at 5 to 8 per minute. Saturations are normal, that indicating that even a breath of 5 to 8 is enough because his lungs are normal. But his rate obviously is really low, and this may be a sign of an increased ICP. We have heart rate which is low, we have a breathing which is affected, we don't have that hypertension of the Cushing's triad, but yes, this is probably a child with increased ICP related to meningoencephalitis. So what would you do? I would immediately start, I'll put a Bain circuit there and kind of get prepared for intubation, start bagging him in the meantime, and whatever treatment, neuroprotective treatment that I have to give, do that, and simultaneously get prepared for putting in a definitive airway. So this is again a central lack of control because of an acquired infection, disease, which may be a meningoencephalitis, but this can be a pointer towards increased intracranial pressure. And the triad of Cushing's, where you have a waxing, waning breathing or an irregular breathing, in addition to a bradycardia and hypertension. So remember, you don't need to have all the three components of the triad for increased ICP. Even one is enough in a clinical setting to say if a child has raised ICP. So we will talk about raised ICP in future talks, but here again I want you to concentrate on the pattern of breathing, indicating that it is a center related problem. So center, the need to recognize really early. Depending on the site of involvement, the pattern can be either a Klein-Stokes, which is a waxing and waning breathing. It can be hyperventilation, as in the case of midbrain lesions. It can be hypoventilation, again, which can happen in any part of the brainstem, like we saw in the first case. It can be apneustic or ataxic. So pay attention to the history, pay attention to the breathing. Irrespective, treatment has to be based on, the primary cause. In the meantime, providing for adequate oxygenation and carbon dioxide clearance. If presentation is acute, need for measures to lower ICP have to be instituted immediately. Like I would give a 3% saline, 5 ml per kg. We would keep the head end elevated. We would immediately intubate and keep the PCO2 between 35 to 40. Do a CT to see what's happening. So all those are neuroprotective measures, which I'll be talking to you in later classes. But this is a center involvement causing an abnormal respiratory pattern. So very important. So we spoke about airway, we spoke about upper airway, lower airway, we spoke about parenchyma, we spoke about the center, and the last one is involvement of the muscle.